Good afternoon, everyone, and welcome. Thank you for joining us for today's Lunch and Learn session, Designing Technology to Improve the Lives of Older Adults, Challenges, Frontiers, and the Futures, with Dr. Charlene Chu. My name is Laura Clark, and I am the Director of Advancement at the Lawrence S. Bloomberg Faculty of Nursing. I'd like to thank Laerdal Medical Canada for supporting this event. Their investment in professional development for the nursing community is very much appreciated by all of us here. Before we get started, I also wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. A couple of quick housekeeping items. We would like to ask that you please keep your microphone on mute for the duration of Dr. Chu's presentation. We do welcome you to enter any questions you have in the chat box, and we will have a question and answer period at the end of the presentation. Also, today's session is being recorded. We will send you an email after the session, which will include a link to the recording, as well as a survey so that you can provide feedback on today's event. It is now my pleasure to introduce today's speaker. Dr. Charlene Chu is an assistant professor at the Lawrence S. Bloomberg Faculty of Nursing at the University of Toronto and an affiliate scientist at Kite Toronto Rehab at the University Health Network. She is also cross-appointed, status only, with the Factor Inwintosh Faculty of Social Works Institute for Life Course and Aging at the University of Toronto. Dr. Chu is a nationally and internationally recognized nurse scientist who has passionately devoted her career to improving the care of the older adult. She is an accomplished researcher who has published over 50 manuscripts, holds 2 patents, and leads an interdisciplinary team of researchers. The quality and rigor of Dr. Chu's work has been recognized and funded by many prestigious agencies, including NFRF, CIHR, SSHRC, and the Alzheimer's Society of Canada, demonstrating the wide appeal and significance of her research. She is a passionate and innovative advocate for digital health and the power of technology to transform healthcare and nursing. Thank you so much for joining us today, Dr. Chu. Over to you.
Thank you so much, Laura, for that lovely introduction. I'm so pleased to be able to speak here today to everybody about aging and designing technology for older adults. Again, I'd like to thank Laura and Shauna and everyone at the Advancements Office for extending this invitation. I'm really delighted to be here today. I also recognize a lot of familiar names in the participant list of colleagues, previous and past colleagues, previous and past team members, students and mentors. Thank you so much for coming and being interested in this work. So again, I'm really grateful to be able to be here to discuss this topic and share, some of my insights on a topic that I'm really passionate about. Let's see. So for today, I've been asked to introduce myself a bit, and then I'll briefly discuss the context of aging and technology that help inform my approach. And then I'll discuss a few of the key challenges to designing healthcare technology more generally, as well as specifically when working with older adults. Next, I'll spend a bit more time talking about my work and how I feel like my work might contribute to help move the needle forward. And of course, I'm going to try to highlight how nurses fit into the picture and how nurses can be drivers of change as well. Okay, so this is a picture of my grandfather here pointing at the screen. You may have seen this picture in more of the recent promos for U of T. And this is not me in the picture here. This is actually my mother. So like many immigrant families, I was very close with my grandfather. He unfortunately, developed Alzheimer's. He broke his hip and he was admitted into long-term care. And he wasn't there long before he passed away. And it was from witnessing the environment as well as the level of care that my grandfather experienced, as well as what the other residents were experiencing, that really inspired my vocation to go into nursing. So I graduated from Bloomberg and I worked in acute care as well as in palliative home care for many years. And then I was able to, and fortunate enough to be a PhD student of Dr. Kathy McJilton. So with her, I learned how to design person-centered interventions in long-term care and post-acute care settings. And it was through her expertise and my opportunities in my graduate program that I was able to develop a really in-depth understanding of interventions and how to design interventions and evaluate interventions. Once I finished my PhD, I went and I was able to be a postdoctoral fellow with doctors Alex Mahalides and Rosalie Wang in a lab that was focused on technology and AI and robotics. And it was here that I was able to work with computer scientists, a variety of different engineers. And I took my background as an interventionist and a clinician and interventionist, and I used that same lens to look at technology as an intervention and how we can use technology potentially as more of a person-centered intervention. So my program of research is really focused on aging, on gerontology, but also exploring the different ways that technology can help improve the lives of older adults and their caregivers while using person-centered principles, not only in the design, but also in the evaluation of the technology as an intervention. So I've been very busy during this time at the faculty as well. So since joining the faculty as an assistant professor, I have over a dozen grants, I have 60 publications, 2 book chapters. I also hold 2 patents. So we hear about this every day. I'm not going to get too much into this, but we know that the world is aging, that we know that there's an aging population, and this trend is certainly mirrored here in Canada as well. And this trend is a concern because, quite frankly, we live in a society that is not optimally created to make it easy to age. Think about our physical environments, our sidewalks, our stairs, our buildings. Jeff Fernie from Toronto Rehab, a lot of his work talked about how codes and structures are not optimized to be senior friendly. Structures like our healthcare system are also not senior friendly, as demonstrated more recently by the COVID-19 pandemic and our response in long-term care. So it's not easy to age in the world that we're living in currently. And this is compounded because older adults who are aging, the ratio of family caregivers who are there to provide care and to provide everyday assistance, that ratio is decreasing. And often family caregivers, are having their own physical and mental health challenges, mostly in relation to their caregiving duties. Often stepping into these roles, you're going to have nurses. Nurses are often at the front lines of care. However, the WHO, in partnership with the International Council of Nurses and Nursing Now, in their State of the World Nursing report in 2020 reveals that there's a global shortfall of nurses, of 5.9 million nurses. And so with these formal and informal caregiving shortages, there creates a situation where we now have more older adults than we have people to provide assistance to care for them. And so my position here is that technology can be a solution. Today's older adults are not only redefining aging, but they're also redefining expectations of what it means to be old, what it means to grow old in our society. And there's a lot of opportunities here. New technology can also create value and benefits on many different levels. It can help reduce healthcare costs, make healthcare more effective, more efficient. It can also help people age in place. And it can make a big impact on individual older adults as well as their families. But of course, this is not without challenges. So some high-level challenges that I'll just mention here. Certainly, there are many more challenges to creating sort of successful technology that is adapted and used in everyday life, but I'll just focus on these for now. So the first one here we can see is different definitions of the problem. So this is when a technology is designed that doesn't solve the problem at hand. So this comes from a fundamental misunderstanding of the problem, of the mechanisms at action that contribute to the problem, and potentially the factors aspects of the problem that are being targeted by the solution don't actually improve the problem at hand. The second is that there's a lack of understanding about who the end user is. The traditional processes of technology development often exclude older adults as the end user, resulting in technology that is neither useful nor viable to implement into practice. And actually, this is the same for nurses as well. Often nurses are excluded from this process as well. And so this exclusion is a long-standing problem. And I'll talk a little bit more about this in my presentation in the upcoming slides. The third is that we have a lack of consideration and knowledge about the context in which the technology or the intervention that we are designing fits into the context and the workflow of the clinical environment. From my previous experiences with engineers and developers and designers, healthcare has been described by tech developers as opaque. So it's very varied depending on what hospital, depending on what jurisdiction, depending on what sector you're working on. It's difficult to really understand the processes that are in place to provide patient care, and access into these places are very difficult. So as such, technologies that are created don't necessarily fit into the environment that they're supposed to be fitting into. I think this also speaks to the siloed nature of how we work and how we are developing these technologies to begin with as well. Fourth, here, this speaks more to the decreased capacity that we have to be able to translate research in the lab into the bedside, into the real world with successful commercialization of health technologies. And this also sort of speaks more to like the regulatory issues as well. And then the fifth is about poor implementation processes that don't support the adoption of the technology at hand. And so an outcome of all of these challenges is that the vast majority of healthcare technologies that are created every year fail. So this is a huge waste of time, of talent, of resources. And I'll give you an example here. This is probably the most famous, most commonly used examples of a lack of understanding about who the end user is. So I think we are all familiar with this type of technology. It's a call bell. You wear it around your neck, and if you need help or if you fall, you can press this button. Previous work looking at this adoption found that 80% of people who use this don't use it. And the main reasons why they don't use it is because they don't wear them all the time. So of course, this technology only works if you wear them, and if the person has it on their person when they fall and when they need it. So you can tell here from this quote, I've already taken it off. I put it at the bedside table, and so they don't have it on them to wear. And then the second reason is that they simply just don't want to use it. Here we have somebody who has it, but they don't want to use it. And this is because they're scared of what's going to happen when they press that button. They're scared of what it means, the stigma, the implications of when others perceive them to be no longer as capable as when they once were. So they don't want to use this type of technology. Older adults believe that they're able to get up on their own, and they don't want to be seen as somebody who's not as capable as when they once were. Another challenge that we have to be aware of here is that technology is an intervention. And so technology interventions are a source of intervention-generated inequity. And this is true, especially as we move more into a digital world. So we must be aware here that the processes of growing old in an increasingly digital world directly and insidiously reinforces social inequities, exclusion, and marginalization. So while technology has the ability to improve access and democratize healthcare to many respects, it also has the ability to be a source of exclusion by means of access, by means of uptake. And I gave my undergraduate students this paper to read this past week. They did amazing presentations about how technology is an intervention that can create inequity. So now that I've sort of given a high-level description of the context and the broader challenges, I want to talk about some of the work that I'm focused on. And so I feel as these are sort of emerging areas of work that address this context and some of these challenges in an innovative way. I've described them as 3 buckets of work. The first is technology as an intervention on its own merits. The second in the middle here is technology as a tool. So as a tool to evaluate the effectiveness of various interventions, not necessarily technology as the intervention. And then third is looking at the intersection between AI and aging. So this is acknowledging, of course, that AI has immense potential for good, for positive change, but it can also perpetuate social inequity and bias. So I'm going to first talk about this, the first bucket. And so the outcomes I'm going to focus on here are physical health and social engagement. So an example of a project here is the exergaming platform that I'm developing with an interdisciplinary team. So the problem that we're trying to address here is that nursing home residents spend the vast majority of their time sitting and in sedentary activities, which has a negative health consequence. A recent paper authored by myself, Kathy Mitchelton, and others shows that residents can experience a significant amount of decline in mobility within 60 days, which is much faster than the 3-month or the 6-month mark that have been previously reported in literature. And so we used a user-centered design approach here, which is based in or analogous to person-centered care, but in a design approach. And so there are many sort of terms that are similar to this, for example, co-design, but essentially we have this collaborative involvement of end users, and then there is a cyclical and iterative process for technology developers and evaluation. So in this case, we have long-term care home residents who participated throughout the development process, and they started right from the beginning with the inception of how to think about the problem, and then putting their perspectives at the center of the design process. And then we ensure that their feedback continually drives the design, the prototyping, the review, and you sort of have this snaking back and forth. In our project, we also included the voices of staff. We also included the voices of their families to try to understand the context as well as their perspectives too. And so the benefit of user-centered approach is that it does help also to support clinical integration into practice as well, because then we can account for the complexities of the long-term care home environment, and then this will also influence our ability to evaluate and implement. Okay, so this work has been published in the CHI conference, which is a very well-known human interaction conference, and it was also published in JMIR Serious Games, which is the top journal for serious gaming. So I'm just going to sort of walk through the process here that we described in our papers. So this idea or this exergaming platform is called MouvMat, and so we applied a user-centered design here. Here we are focused again on residents without any conception of what the solution might be. We first want to identify what the problem is. What are the factors that contribute to this problem? This is a picture of our very first resident that we interviewed. This was in Shediac, New Brunswick, as part of the Age Well Summer Institute. And once we came back to Toronto, we continued to interview nursing home residents, and we applied for funding to try to create a paper prototype and create a mock solution of what, when we worked collaboratively with residents, what addressed the problem at hand. And so this is the mock-up that we came up with. This was our paper prototype. So this is an innovative adaptive surface that we co-created with older adults. It was built for long-term care home environments. That is, it's easy to store, easy to clean, easy to use. The concept here is that it's a collection of adaptable, pressure-censored, magnetic tiles. And these squares, you can throw them on the ground, they click together instantly, and you can form different formations and play different games on them. So we started rapid prototyping this idea. We asked residents what they thought of this idea, what was some feedback, and then we started prototyping. And so here you can see that when we're rapid prototyping, we just want to see how people are interacting with it. This is something that they haven't interacted before. So are they comfortable, navigating the physical space with this there? How are they holding their walkers? How are they, are they looking around? Are they paying attention? So we're really paying attention to how it is they're interacting with a new type of technology that is introduced into the environment. And so you can see here that we're testing it with staff, we're testing it with residents who are using a walker, and then we're also testing it with residents who are in a wheelchair as well. And so it was through this testing that we continued to not only create this peripheral accessory that could be used for residents who are wheelchair dependent, but we also learned a lot based on their feedback. So we continued to iterate. We did rounds and rounds of iterations, each time based on their feedback, building it in, rapid prototyping, bringing it back, having them try it, taking it back, and having their feedback drive all of the innovation. And so here again, a different formation. We tried it on the tabletop, we've tried it on a wall. And so there's been a lot of iteration here. Eventually, we came to more of a high fidelity prototype. So these are prototypes now that have the sensors embedded in them, that have proper LED lights, that have the magnets in them. And so again, here we're trying them with different residents, different formations, different games. The games that we developed here were in conjunction with our partners at Sheridan College in order to design the technology as well as the software that can then appeal to the needs of these residents. And so with every iteration, we're conducting interviews. This is my co-PI, Renee Biss. She's an assistant professor as well as a clinical neuropsychologist at U Windsor. And eventually we ended up with our current prototype here. And so this is, and actually now we've made it wireless, so there's no wires on it whatsoever now. And so our next step here is to evaluate the feasibility, acceptability, and efficacy now of this exergaming platform. So we're going to conduct a pilot RCT in multiple nursing homes. The intervention will be 6 weeks long, 4 times a week. It's been registered on clinicaltrials.gov, and so this will be starting in January. And then our funding agencies are at the bottom there. So next I'll move on to technology as a tool. So again, this is a new type of technologies that we're designing that we feel will be important to now evaluate the effectiveness and also just have a better understanding of how older adults are interacting with technologies as well as other types of interventions. So the main system that we focus here on, and I work very closely with my co-PI on many of these projects, Dr. Shiroz Khan at Toronto Rehab. And so our main idea here is that we use smart home technologies. So these are bespoke smart home technologies that are built on the idea of Internet of Things, or technologies that are able to collect large amounts of different types of data within a person's home, and it's able to do that in an unobtrusive way. So you can imagine the application and the potential of a system like this, where we can help decentralize care into the community setting, as well as support aging in place. So with the idea of smart home and smart home technologies, which most people are familiar with, we are pairing this with a research methodology that is the ecological momentary assessment. And so this is essentially a digital diary where we leverage mobile technology, and this is how it's commonly used in patient-oriented research. So we use EMAs as a method to collect data in real time based on individuals' symptoms, their affect, their mood, their behavior in their natural environments. And this is also appropriate and has been tested for caregivers as well. And so together we feel that this pairing of objective data as well as behavioral and subjective information helps us really form a cohesive and fulsome picture of interventions in real time, in real world conditions. So the next couple of slides are some projects that we're using this type of technology on. So the first is to detect and assess social isolation. So when older adults are discharged from having a hip fracture and they go back home into the community, it's unclear about how their physical recovery interacts with their ability to participate within their in their community, and how that might interact with their ability to socialize and connect with others. So we're using this technology to follow a small group of patients who are being discharged from Toronto rehab back into the community in order to have a better understanding of their recovery process. The second application of the sensor system that we've developed is to use it as a measurement tool to evaluate and get various insights. So one of the various interventions. And so one of the interventions that we're looking at is cannabis. And so we know that since cannabis was legalized in Canada in 2018, that cannabidiol or CBD oil has been very, very popular amongst older adult use. And so this is for a multitude of reasons: pain, insomnia, anxiety, nausea. So CBD is the non-psychoactive cannabinoid of the cannabis plant. But yet, despite the high use of CBD oil in older adults, there hasn't been any studies examining what changes occur when older adults who have dementia are taking CBD. And so we're using this technology to examine and observe how older adults who are living at home, who have dementia, who are living at home with their caregivers, how they change over time. And again, we're collecting subjective and objective data over a period of 8 weeks. And then the next area that I'll talk about here in the last few minutes, is aging and AI. So considerable amount of attention has been given to structural societal biases. So this is primarily in relation to racism and gender-related biases, and how these different biases can be manifested in AI. So a lot of these headlines I don't think are surprising, but the idea here is that we assume that AI is objective, but there actually has been a lot of reports of bias being introduced in AI. So for example, we've had racialized groups being excluded from healthcare services, different racialized groups receiving longer jail sentences, and they're misidentified by police at a rate that are 5 times higher than Caucasians, for example. There's also rampant bias against women, especially related to job discrimination. So for example, job ads that are more highly paid positions are less likely to be presented to women via various algorithms that women who may be looking for jobs. So despite this increased attention to bias in AI, as well as more attention focused on fairness in AI, very little attention has been paid to an age-related bias in AI. So this is the next sort of arm of my work, and I'm leading a study that's been funded by SSHRC. And so again, multidisciplinary approach where I'm collaborating with computer scientists, bioethicists, critical gerontologists, legal scholars, public health researchers to investigate bias and discrimination as it pertains to older adults and AI. So our research questions here are: how does AI encode, or how do AI systems encode, produce, reinforce age-related biases? And then the second is to identify what is the extent to these age-related biases and how does it impact older adults. So in this work to date, we've conducted a review of the AI Ethics Guidelines Global Inventory. So this is a repository that compiles documents about how AI systems can be used in an ethical way, essentially. And so there was 146 documents from nonprofits, various organizations, for-profit organizations, academic and civil organizations, and there was only 34 mentions of age. And so again, all of these documents are focused on how we can produce AI systems that are fair, and there was only 34 mentions of age. Often it was only in passing in a list of other strata that we need to be familiar or that we need to be aware of. So age was not looked at in an in-depth and meaningful way in all of these documents. We are currently conducting a systematic review that is currently underway, and our paper was recently just accepted for the gerontologist, and this provides more theoretical understanding of digital ageism and what are some of the challenges and opportunities in digital ageism. And I just want to describe that a little bit more in this next slide. So the ways that we've thought about how age-related bias is then encoded into AI systems are what I am calling cycles of injustice. So we have these various cycles of injustice that are all interrelated. Ageism plays a very big part in this phenomenon, and that is then threaded throughout the pipeline of development, testing, the use, and so then this is how ageism may be exacerbated. And so our paper talks about this, and we're also writing a book chapter that is looking at this from a feminist lens, and that'll be published in January. And so although there's inherent risk in being interdisciplinary and designing with older adults, like for example, it takes a longer period of time. It is more research intensive, but there are a lot of benefits. The challenges that have also been brought up in the literature as well is that people come to the table with these assumptions, with ageist assumptions at hand. So there has been research shown that the developers who are trying to develop technology with older adults, even though there are older adults sitting at the table, they tend to project their own needs and wants onto the technology instead of the older adults, even though they're present at the table. And so this links into the ability to be able to be inclusive and equitable. So even though we are including older adults into this participatory and co-design process, we need to be inclusive, thinking about different decades, different races, genders as well, and then the idea of being equitable. So if they older adults are playing a key part in forming the research problem, interpreting the data, helping make sense of the data, then they should also be co-authors too. Where is the ownership and credibility? So that is an ongoing discussion. We also want to pay attention to access and representation. Can we access and represent not only older adults now, but who will be older adults in the future? So who are we designing for? The older adults now or older adults in the future? It's also an ongoing point of conversation. Others are challenges in language and vocabulary. So certainly if you are working in a multidisciplinary team, different disciplines use the same words, but they mean different things. And so not having a team that is on the same page can really lead to a lot of miscommunication. And then also working with individuals too who just don't have an open mind about looking at problems in different lights and using and applying different concepts and theories. So there are many challenges in the approaches that I'm suggesting and the approach that I'm taking on, but I do think that the benefits outweigh the risks. And so context matters here when we're thinking about technology, when we're thinking about older adults, and certainly the social and ethical aspects need to be considered and incorporated into the entire development pipeline, as well as the implementation pipeline. I'll also just add here that nurses are being more recognized in this context. And so nurses are being recognized to be able to bridge that application between lab and practice. Nurses, first of all, produce the most healthcare data in our EMR systems. They're often the highest, most often the end users as well of healthcare technology. And so they are being more recognized, and nurses do have a role in moving the needle. With respect to training, there are really innovative training hubs that are focused on aging, that are focused on technology. Ones that I'll mention here is AgeWell. So they have a lot of training opportunities. This is a network that is focused on designing technology for older adults. And then we also have the Institute of Aging and Life course at the University of Toronto. Our MN students here at the faculty have the ability to participate in a collaborative program between the Faculty of Nursing and the Institute of Aging, and that provides them with the ability, again, to be multidisciplinary and start that training early. So in conclusion, technology has a lot of benefits, but is also a source of inequity. Older adults have traditionally been excluded from the process, but there are user-centered methods and other methods that can be adopted. In my work, I've shown that user-centered methodologies are feasible with older adults, even with varying physical and cognitive abilities. And then also the social and ethical aspects need to be considered when designing technology. And so I think that by working together, we do have a better chance of meeting our collective aspirations in order to improve care for all. So I just want to acknowledge my team, my mentors, my students, my previous students who are on my research team. And I want to thank everyone for their time and attention.
Thank you so much, Charlene. That was a really great presentation. I would encourage anyone who has a question to enter it in the chat box, but I can see Shirley has had her hand up. So Shirley, did you want to unmute and ask your question? I don't know if maybe she doesn't have, maybe she accidentally put her hand up. That's something that happens. So does anyone have a question? I'm happy to read it out from the chat box, or if you'd like to raise your hand, we can also do it that way. Jean Hallett-Sims, would you like to ask a question?
Yes, Charlene said that everybody knew what smart homes were. I graduated from U of T in nursing in 1961. I don't know what those smart homes are, and I would like to know more about that because I'm in the age group that is needing more of those smart homes to help me be able to stay at home.
Thank you so much for your question. So I apologize. I shouldn't have brushed over
that was an assumption, I think.
Yes, that was an assumption. So smart home technology is leveraging the idea of Internet of Things. And what that means is we can have electronic sensors that are placed around the home that help make it easier for older adults to live independently. So for example, you can have sensors on your lights to turn on at a certain time. You could have your coffee maker turn on at a certain time. You could have your TV turn on at a certain time. And so in addition to some of the appliances that can be coordinated, you can also wear a wearable device, and that will track your position within your home. It can tell you how many steps you've taken throughout the day. It can tell you how long you've been sitting in a chair, how long you've been sleeping, with other sensors like mattress pads and chair pads. It's basically setting up your home with a variety of different sensors and a variety of different technologies that will monitor and collect data as you move about. And should something happen, or should it be able to detect trends potentially that could be interpreted and then transmitted to whoever you might want it to be transmitted to. So whether that be a caregiver, a physician, somebody on your healthcare team.
Okay, but I do need a smartphone, right, to get these apps to do this stuff?
Yes, you do.
Okay, because I have not yet invested in a smartphone, and some of my younger friends are telling me I have to come into the 21st century so I can get Siri to do all that stuff for me. So since I can't go away to the south this winter, I think I'm going to invest in a smartphone. Thank you. Oh, I want to tell you, I just recently was a member of Weight Watchers trying to get off some of my COVID weight. And they supposedly personalized the program this time. But if you didn't have a smartphone to buy their app, you couldn't you couldn't record your exercise anymore. You couldn't get your water that you drink counted. And each of those things would count for extra points that you could add on to your daily points. So I felt very discriminated against having, been a member of their program off and on for the last 50 years or so. And I put that on Facebook, and only one person who had been a former leader of one of my Weight Watcher groups responded to me and said, I'll bet there's lots of other people like you, and I will go and talk about it with them. But I think they have enough young people. They don't really care about us.
So thank you very much for your comments. And I think that's incredibly indicative of really at the heart of what I'm talking about.
Absolutely.
And really at the heart of what I'm trying to do with my work. Because as we move further and further with digital technology and into the digital age, there will be older adults who will not have access or an understanding and the ability to use these technologies that have not been designed well. And so the people who are designing it, various technologies, we need to be able to collaborate with older adults to be able to use this technology. Because again, going back to the more recent work, it's a cycle of injustice. We have people who are designing technologies using their own biases, designing technologies for who they believe older adults to be, not necessarily designing technologies for older adults themselves. Therein, those people who are designing or using that technology are a very segmented part of the population. And then that segmented part of the population has their data collected. It is not representative of all older adults, and then continue on, and then that data is then used to develop more technology for that, again, more segmented part of the population. So it is a discriminatory process. It's a very social exclusionary process, and one that can marginalize a lot of people. And thank you very much for sharing your experiences, because this is exactly what I'm talking about. And if you want to be involved in any type of research, please reach out to me.
I will. I'd love to.
I'd love to have you. Thank you.
Okay.
Thank you so much for that question, Jean. That was really great. I'm just going to point out, Charlene, that there's some great comments in the chat, including AMS Healthcare is saying that you should consider applying for some of their new stream of funding for compassion and AI. So I'm just going to point that out to you. And then I also want to relay a question that we have from Kitty Yin. She says to thank you very much for the presentation. And then, in designing for the older adults of today and tomorrow, are the needs of our future older adults much different than older adults today? How should we direct patient-oriented research to reflect the needs of the future generation of older adults?
That's a great question. Are the needs of future adults, older adults, different than, well, older adults in the future will be or I think will tend to be more technology savvy. When you look at the adoption of technology, more and more adults are using technology, especially over the course of the COVID pandemic. The greatest gain in technology use has been in older adults, especially also with internet usage as well, has been in older adults. So I think as we are slowly making these gains and older adults are continuing to adopt and uptake technology, we're going to see older adults demanding more of technology and demanding that technology is useful for a young person who's living in their home who wants to track their steps, but it's not necessarily being used to track the health of older adults, and that can be utilized in that way, in a meaningful way. So I think that's a really great question. How do we direct patient-oriented research to reflect the needs? I think this too also goes back to one of the challenges that I brought up in one of my slides, which is having adequate representation. So when you're working with older adults and you're perhaps using a methodology like user-centered design or co-design, you want to make sure that the older adults that you are including are sort of, spanning the, not just 80-year-olds or 90-year-olds, but you're also including 50-year-olds, 60-year-olds. So you want to try to include a wide variety of people to try to understand how you can develop technology that has the ability to be nimble and has the ability to adapt. So you want to create features in various technologies that can change over time alongside with the end user, who also might change over time and who is aging over time. I hope that answers your question.
Thank you so much, Charlene. Does anyone else have any questions for Charlene? You can either raise your hand or enter it in the chat. No. Okay. Well, thank you so much, Charlene. That really was a very informative presentation, and we really, really appreciate your time today. I want to thank all of you as well for attending today. I know that we're all getting to the point where online events are becoming a bit more challenging, but we really appreciate you attending today. I think you've all gotten some great things to think about. This is our last Lunch and Learn for 2021. We will be hosting our next session on January 18th. Which explore the topic of strategies for approaching ethical dilemmas and decision-making in nursing with some guests from the Cozy Brocky Law. We will be sending an invite out for that soon. I also want to once again thank Laerdal Medical Canada for supporting this series. And as Charlene said at the beginning, I want to thank Shauna Spicer and Carolyn Peralta for organizing today's event. And again, for all of you for joining in the enriching conversation today. Thank you so much and have a wonderful day.